We had come to the discussion on therapies for autoimmune disorder. There I was explaining to you about the immunosuppressive therapy, which is chemical based, or it is also called as chemotherapy. And the same drugs are used for cancer suppression as well as in the person who receives the tissue graft. Okay, during transplantation also same drug is used. I'll just make a passing remark on the drugs that are being commonly used, but I will give you the detailed explanation when I'm going to talk about the immunosuppressive therapy in cancer or during transplantation, that is in the unit 5. So the drugs that are used are azathioprine, one major drug, azathioprine, which has been in use for now many years, almost 50 years. Very strong drug. Okay. Then there is another drug called as cyclophosphamide, then methotrexate, then cyclosporin, and then corticosteroids. Among all these drugs, corticosteroids are the only mildest ones. But corticosteroids are administered together with other strong immunosuppressive drugs. And corticosteroids are administered to prevent inflammation because they are strongly anti-inflammatory, corticosteroids. So they are administered always, having mild effect, but at the same time prevent inflammatory reaction. So more details, I will talk about that in the later chapters, that is in unit 5. Now we'll come to the another important method that is used for giving therapy to the autoimmune patients, that is plasmapheresis, which is very, very safe and good enough to help the person to lead a normal life. Only thing is, the person has to visit the hospital every month. Every month he has to go, and this plasmapheresis is done just like the way the dialysis is done. There are plasmapheresis machines, and there is some amount of fee has to be paid. The person's blood passes through this machine. As the blood is passing through this machine, the anticoagulant is added to the blood, and the plasma is separated from the RBCs, and the separated RBCs are mixed with the new fresh plasma which is obtained from a healthy person. Fresh plasma obtained from a healthy person. Nowadays, the plasma is also available in the form of powder, that is lyophilized plasma, that can be resuspended in human saline, which is buffered saline. And after resuspension, the same plasma can be used for reconstitution of the RBC that was separated in the plasmapheresis, and it is recirculated back into the patient. Now, the plasma is removed from the patient. Why? Because the autoimmune patient will be having autoantibodies circulating in his plasma. And those autoantibodies are the one which are causing damage to his tissues. So once you get rid of these antibodies by this plasmapheresis method, by removing his plasma, diseased plasma, and giving the person new plasma, that is fresh plasma, the person will have a relief, and the disease can be slowed down. The progression of disease can be slowed down. It will take another 1 month for the person to produce the antibodies once again against his own self antigens. By then, once again, he is ready to go to the hospital for plasmapheresis. Like that, plasmapheresis has to be repeated every month. Why? Because within 1 month, once again, the antibodies will come to the high titer to cause the damage. But it is very simple and very safe approach. And it doesn't involve any kind of harshness or cause any damage to the person, and it will be useful for the person. But only thing is, plasmapheresis apparatus instrument should be available in that particular place, and it is like dialysis, it is also costly. It has to be subsidized. Then comes another harsher approach is thymectomy, removal of the thymus, which is also safe but at the same time dangerous. The reason being, you know that thymus is the primary lymphoid organ together with bone marrow. Bone marrow is also a primary lymphoid organ. After removal of the thymus, the person will not be able to involve his T cells. T cell maturation process will be stopped. Thymus is very much essential for the T cell maturation process. And those T cells that are positively selected and negatively selected keep visiting the thymus until they come in contact with the antigen. But autoimmune cells which are there in the thymus, they would cause damage to the person. So therefore, thymectomy is done, thymus is removed. Then the person will be totally deprived of all immune response. It will be a total suppression in the sense, you know that long-term B cell response, acquired immune response, and acquired immune memory is dependent on the T cells. TH cell dependent B cell activation we have already discussed. Without the involvement of TH cells, if the B cells are activated, they do not provide long-term immunity. They cannot provide the class switching mechanism. They will keep producing only IgM antibodies and their lifespan is very, very short. There is no acquired immune memory. If there is no acquired immune memory, the person will be totally dependent on the T cell independent response, which will not be good enough. Reason being, the intracellular pathogens like bacteria and virus will take this as an opportunity to infect the person, and those intracellular pathogens will not be removed from the body by the antibodies because antibodies cannot penetrate the cells. It will be a severe combined immunodeficiency after removing the thymus. Then you have to save the person by keeping him in the aseptic condition all throughout his life, preventing him coming in contact with any antigens of foreign origin, which is a very, very difficult task. Very, very difficult task. Because the opportunistic pathogens would infect the person at any cost, whatever the amount of care you take, and at that time, it will be debilitating for the person. So therefore, this practice is not done now, thymectomy. It was very old, age-old practice. It has stopped, but it is one of the method. That is why I explained to you. But nowadays, most of the doctors do not prefer to do that. They would advise milder doses of immunosuppressive therapy and plasmapheresis, or if the person can afford it, they will go to the next therapy, and that will be monoclonal antibody therapy. But before that, I'll discuss another therapy, that is T cell vaccination, which has not yet been practiced. It is done for very few patients. It is practiced in the United States with the primary consent of the patient suffering from multiple sclerosis. It has been used only against multiple sclerosis patients, not against other type of autoimmune disorder. Let me be very clear here. And still, it has not been practiced universally, but it has worked out very well for the patients who are suffering from multiple sclerosis. And it was devised. In fact, it came into the practice of some doctors who did research on it in the year somewhere between 2003 to 2005. Okay, and those patients survived the complete life for after initially showing multiple sclerosis symptoms. Later, they survived without the progression of the disease, had a healthy life, and then they passed away. How did they do this? This is called as ex vivo therapy. Ex vivo therapy is nothing but the patient's cells are taken out. All right. Now here, because for the multiple sclerosis, it is a T cell mediated response. T cells of the patient should be harvested. And they could harvest TH cells from the patient's cerebrospinal fluid, CSF. One can be tapped in the spinal region with a long needle by tapping cerebrospinal fluid, one can harvest T lymphocytes, which are there in the cerebrospinal fluid of the patient. Okay, because the TH cells have invaded the cerebrospinal fluid and the brain vesicles, the person suffers from the multiple sclerosis. Please remember that. So therefore, they could harvest these T cells. After harvesting, these T cells are cultured in the laboratory. They are allowed to undergo proliferation. And T cells undergo proliferation if you provide IL-2, that is interleukin-2, which is the T cell growth factor. By providing T cell growth factor, they could proliferate these T cells. As they were proliferating, these T cells are already sensitized against the myelin basic protein. Please remember, they are harvested from the patient who is suffering from multiple sclerosis. It is nothing but autoimmune response against the myelin basic protein. So those harvested T cells, which are now growing in the laboratory condition in vitro, to them they added myelin basic protein in the media. When they added myelin basic protein in the media, since these T cells were already sensitized against the myelin basic protein, they formed a cluster around the antigen. The T cell receptors formed a bonding with the antigen. Otherwise, T cells by themselves do not recognize the antigen. They have to be presented antigen, that is TH cells have to be presented antigen on class 2 MHC by the antigen presenting cells. Then only they receive the signal and they get activated. Now these cells were already activated against the myelin basic protein in the patient. Now what do? They have added the myelin basic protein in the media. As soon as they recognize that myelin basic protein antigen, their receptors were sensitized or compatible, having high affinity to that antigen. They formed a rosette formation, means clustering. The rosette formed T cells around the myelin basic protein antigen were harvested. Okay, those cells which had formed a rosette, ROSE double TTE. Okay, ROSE double TE, rosette formation means clustering. Those cells were harvested from the medium, given back to the patient through intravenous route. After those cells were given back to the patient through intravenous route, they found that the progression of the disease stopped. The patient responded positively, and this approach was done for about 10 patients who volunteered by consent, and they were relieved and the disease progression stopped in them. In the sense, because of the rosette formation, and had mentioned to you, when the overwhelming amount of antigen is present, the T cells develop tolerance. I had mentioned that to you. Therefore, excess amount of antigen should not be given to the person, and the excess amount of antigen should not form the bonding with the receptor. Here you have done it artificially. In the body, it would not have happened in vivo or in situ, inside the body of the patient. Here now in vitro you have done it, and once that was done, those T cells became tolerant and they stopped the immune response, or they stopped getting activated against the myelin basic protein. And once that happened, the patient was relieved of multiple sclerosis symptom. And all those 10 patients who went through this therapy, T cell vaccination. Why it is called as vaccination? Because the patient's own cells were given back by triggering them or by pulsing them with their antigen. That's all. And they were given back. That is why it is called as vaccination. And the patients were relieved of the disease. But at the moment, still it has not been approved by the FDA. It has not come into place. And there is a lot of counter arguments going on between the scientists. Still, it has not come into the practice. Let us hope that one day it becomes the therapy for the multiple sclerosis patients, only for multiple sclerosis, not for other autoimmune disorders. Fine. Then we'll go to the another therapy, that is monoclonal antibody therapy. This monoclonal antibody therapy is safe. At the same time, remember that it is also immunosuppressive. It is also immunosuppressive. It is immunosuppressive. Why? Because it is going to act on certain receptors of the immune cells and block them. But receptors are the common features of all the immune cells. You cannot direct them directly against only autoimmune cells. Means those cells which have been stimulated for the autoimmune response. It is not possible to direct them. So let us take one by one. What are those monoclonal antibody therapies available? I'll show you the pictorial diagram also little later. So first monoclonal antibody therapy is against the T cell receptor or IL-2 receptor. IL-2R stands for IL-2 receptor. TCR stands for T cell receptor. So the monoclonal antibodies are designed in such a way that they go and bind to the T cell receptor at the antigen binding group. Now let me take the diagram and explain. Here is the T cell receptor of the autoreactive T cell. The monoclonal antibody goes and binds in this region in the antigen binding groove of the T cell receptor. When it binds to the antigen groove of the T cell receptor, that space will not be able to bind to the antigen presented by the APC on class 2 MHC. So that is how you block the T cell receptor from getting activated by the autoreactive self antigens. So the self antigens presented by the antigen presenting cells will not be able to activate the T cell because the T cell receptor is blocked. The next thing that I told you is IL-2R, interleukin 2 receptor, which is always there on the activated T cell, and that keeps receiving the autocrine signal. Means T cell itself produces the interleukin 2, which acts on the T cell as a autocrine self and makes those T cells proliferate. So the monoclonal antibody designed to bind to the IL-2R receptor, okay, IL-2R receptor will block that receptor so that the T cell proliferation can be blocked. Okay, T cell proliferation can be blocked. So such type of monoclonal antibodies are available. But remember, you cannot direct this monoclonal antibody to act only on the autoreactive T cells. There may be other T cells which are not autoreactive. All T cells in an autoimmune disorder patient should be, all T cells need not be autoreactive. Some T cells are meant for some pathogenic antigens. They are responsible for protecting you from the pathogenic infection. All right, other antigens. So if those T cells also get blocked while the monoclonal antibody is used, it will become a general blockade of the T cells. Please remember that. Almost all T cells will be inhibited from getting activated. Once again, the person gets immunocompromised. This is the word used. Immunocompromised means immunosuppressed. And it could be total immunosuppression because you are giving the monoclonal antibody to block the IL-2R receptor or block the TCR receptor, blocking the T cell activation. Okay, there is another possibility also, where a monoclonal antibody will be designed to block CD4 together with TCR plays a major role in TH cell by providing signal 1. I told you that this is the core receptor which has a long cytoplasmic tail of about more than 25 amino acids. CD4 interacts with the beta-2 domain of the class 2 MHC. Since it interacts with the beta-2 domain of the class 2 MHC, simultaneously when the TCR is in contact with the antigen, it is responsible for the activation of T cell. Okay, so one can block the CD4 receptor by producing the monoclonal antibodies, which will go and bind to the area that is capable of binding to beta-2 domain. It will block the binding with beta-2 domain. So that is another approach. Only thing is, one can control the dose of these monoclonal antibodies so that all T cells do not get inhibited. Some will be active, some will not be active. Like that, you can balance the act so that the disease progression can be blocked. Okay. Then there is monoclonal antibody against the TNF alpha. TNF alpha, which is monoclonal antibody called as infliximab. Please remember, majority of the monoclonal antibodies which are come in the therapeutic use will end with MAB, name MAB. Exception, the next one. The next monoclonal antibody is not ending with MAB. The first one is for TNF alpha, that is tumor necrosis factor alpha itself. Directly, it will block the tumor necrosis factor alpha. The second one, that is the third one, sorry, monoclonal antibody against TNF alpha receptor, which is called as etanercept. Why it has been called as etanercept? Because it is against the receptor monoclonal antibody. The short form of the receptor, they have used the word etanercept. Okay, so TNF alpha receptor monoclonal antibody is called as etanercept. TNF alpha monoclonal antibody is called as infliximab. Either of them can be used. Okay, they found it gives quite a good amount of relief in majority of the autoimmune patients. The reason being, TNF alpha is found to be in high levels in almost all autoimmune patients. It is an inflammatory cytokine and produced by the activated macrophages, and activated macrophages will produce it in large quantities plus activated Th cells. Okay, both activated Th cells as well as activated macrophages. And let us presume that in the autoimmune response of a person, both these cells are activated against the self-antigen. And because they are activated against self-antigen, they are producing these cytokines. And this cytokine, if it is blocked, to a great extent, one can block the progression of the autoimmune response, because majority of the autoimmune disorders are inflammatory disorders. Whether it is rheumatoid arthritis, whether it is Hashimoto's thyroiditis, whether it is the type 1 diabetes mellitus, that is deficiency of insulin, whether it is Goodpasture syndrome or Graves' disease or the myasthenia gravis, any one of them, they are inflammatory responses. They could be blocked. And I had mentioned that there is DTH response, that is delayed type hypersensitivity response, in almost all these autoimmune diseases. And that DTH involves Th cells. And when the Th cells are involved, that is Th1 cells, and Th1 cells are inflammatory cells. So that can be blocked by blocking TNF alpha as a cytokine which is blocked, or TNF alpha receptor. There are other anti-inflammatory cytokines that are produced when there is proper immune regulation in the body. Those two anti-inflammatory cytokines are IL-10 and interferon beta. Okay, they are produced in our body if there is a proper immune regulation, and inflammatory response comes down gradually, and it is going to be suppressed by these two cytokines by our body. And all the time, inflammatory response is not kept at an active state. But unfortunately, these two cytokines are in very low quantity in autoimmune patients. It was found that by artificially giving the injections of these two cytokines, that is IL-10 and interferon beta, to the patient, one can relieve the progression of the disease of multiple sclerosis, myasthenia gravis, and rheumatoid arthritis. Rheumatoid arthritis is termed as RA. Okay, one can relieve the patient from the progression of the disease. Okay. There are other monoclonal antibodies that are available. Those will be responsible for blocking the antigen site, binding site of the MHC molecule. Okay, antigen binding site of the MHC molecule, class 2 MHC molecule specifically, that antigen group, thereby preventing the antigen presenting cell from presenting that antigen. Okay, there are also some more monoclonal antibodies which I will be discussing about them in transplantation immunology as well as in the cancer therapy. Remember, we had come across B7 molecule of the antigen presenting cell, and the B7 molecule interacts with the CD28 of the TH cell. Okay, CD28 of the TH cell. So CD28 produced by the TH cell due to activation, either you can block that CD28 of the TH cell by monoclonal antibody, or you can block the B7 produced by the activated antigen presenting cell. Any one of them can be blocked. Each company which proliferates or comes up with monoclonal antibody will use one receptor. So they will become billionaires. So one company produces the monoclonal antibody against B7, another company produces against CD28. So both will earn revenue without trespassing or without violating the rights, trademark rights of the other company. Similarly, we had come across CD40 and CD40L. CD40 receptor is produced by the antigen presenting cell and CD40L produced by the TH cell. When those two receptors come in contact, they are co-stimulatory molecules. They are also responsible for signal 2. Okay, there are monoclonal antibodies available to block CD40 as well as CD40L, CD40 receptor as well as CD40 ligand. So once again, by blocking those, co-stimulatory signal for the TH cell can be blocked. This is how the monoclonal antibodies have helped to alleviate the autoimmune disorder disease from progression. So there we finish as far as autoimmune disorder is concerned. So I will stop sharing this slide and I will move to the next the disorder that is caused by a pathogen, that is HIV virus, which is HIV induced immunosuppression. And we will see the mechanism that is involved in the immunosuppression by the HIV virus. So I'll proceed with that now about the HIV induced immunosuppression, which also comes under immune disorders. This is all the topic that we are talking in the unit 4 or immune disorders. First immune disorder that we talked about was hypersensitivity, which is overwhelming response of the immune system resulting in adverse reaction. Second, we spoke about autoimmune disorder, which is also an immune disorder where self-antigens against which the antibodies are produced and individual undergoes destruction of the cells and organs. We'll talk about now a pathogen-induced immunosuppression or a disorder, HIV. Here, I'm not going to talk about how the HIV infection takes place, how it multiplies in the cells, what happens in the cells, all that you have already studied. We will concentrate only on the mechanism adopted by this virus to survive, and you won't believe, even today, and this virus was discovered in the year 1980. You were not even born at that time. 1980, this virus was discovered, and till today, there is no vaccine or there is no proper immuno drug that is available to protect the person from this virus. Okay, the reason being it attacks the immune system itself. Since it attacks the immune system or the cells of the immune system, the vaccination process will not be useful. Okay, let us just for your understanding purpose, it is not necessary for you to remember this diagram. only from the point of view of knowing those proteins against which we have to, because those are the proteins that are responsible for causing the immunosuppression. First major, this also looks like a coronavirus only, because this is also an RNA virus. And look at those spikes on its body. It also looks like the spikes of the coronavirus. It is only the difference is this causes the immunodeficiency. Coronavirus causes the cold cough like symptom. That's it. The proteins that are present are only different, but the architecture is almost the same. This is the spike protein. So GP120, which is present on the protein coat of the virus, the external most domain is GP120, and the stalk of that is GP41. Okay, that protein is the membrane protein. Then there is a protein called as P17. GP is for glycoprotein, short form for the glycoprotein. And there is a protein that is the capsid, and that protein is P17. And there is a nuclear capsid against the nucleic acid, that is P24. Okay, the nuclear capsid. And remaining other proteins are not very important, because antibodies are not produced against them. Antibodies are produced against GP120, GP41, P17, and P24, and antibodies are detected in the patient who has undergone HIV infection only in the initial stage. When the fresh infection takes place, within 2 years or 3 years time, these antigens, that is GP120, GP41, P17, P24, can be detected in the person. The antibodies can be detected. Later, the antibodies cannot be detected because that virus causes the immunosuppression. There will be no antibody production. Then only you can detect these antigens as soluble antigens in the serum of the patient. They will be available as soluble antigens, as GP120 antigen or GP41 or P17 and P24 will be available as soluble antigens, which can be detected by ELISA or radioimmunoassay. Only these two are the techniques that are used, because both are sensitive, of which radioimmunoassay is the most sensitive, which will detect the minutest quantity of this antigen in the patient's serum or the plasma. Other than that, it is not possible to detect the antibodies, because the person will have suffered immunosuppression. Now, the mechanisms we'll talk about. First, we'll take GP120, which is the major culprit. Okay, GP120, which is present on the virus, can be released into the blood plasma of the patient after the infection, will be available as a soluble protein, glycoprotein, freely. And being free in the plasma of the person, it can directly go and bind to CD4 receptor of the Th cells. It has a strong affinity to CD4 receptors. Okay, so since it can directly bind to CD4 receptor of the Th cell, after binding to CD4 receptors, it can do two things. One, it can facilitate the uptake of the virus, virus, through the GP120, which is there on the virus, to be taken by the Th cell. Or soluble GP120 can bind to CD4 receptor and prevent that CD4 receptor from activation of the Th cells. Okay, now we'll see those mechanisms one by one. All right, so this is the mechanism by which the virus enters the cell. The GP120 binds to CD4, the viral GP120, not the soluble one, which is there on the virus, and it facilitates the fusion of the viral protein coat with the Th cell. And CD4 receptor is there only in the Th cell. And by fusion of the viral coat, it will release that nuclear capsid into the cytoplasm of the Th cell. Once the nuclear capsid is released into the cytoplasm, that Th cell is now going to be taken over by that viral nucleic acid. And that Th cell has become defunct. It is not capable of performing its normal function now. it cannot be immune active anymore. It has been taken over by the virus. And now you know, if the virus load is very, very high in the body, each and every T cell, Th cell that is produced in the body, which is present in the body, can be attacked by HIV virus, because the GP120 has a strong affinity to CD4, and almost all T cells, not even a single T cell will be spared, will be infected by the HIV virus. So once the Th cell is infected by the HIV virus, that Th cell is useless. It cannot do the normal immune function. It cannot help in acquiring the immune response. It cannot produce the cytokines, etc., etc. Now, how does the depletion of Th cell population take place, or T cell population take place? We will see one by one. One is that GP120, soluble GP120 can bind to CD4 receptor of the Th cell. Once it binds to the CD4 receptor, as I told you, in the early infection, when the fresh infection has taken place by the HIV virus in the patient, he will have recognized that 120 as an antigen and started producing the antibodies. At that time, still Th cell depletion has not taken place. It is some fresh Th cells which are not infected by the virus are available. And because of that, Th cell mediated B cell activation has taken place. Antibodies have been produced. Initially, good amount of antibody will be there for GP120. Now, let us presume that GP120 is bound to CD4 receptor of the Th cell. That is the later part of the disease, progression, as the disease is progressing. The antibody comes and binds to GP120. It will be like, see here, antibody is bound to the GP120. Now it can trigger two mechanisms, that is, the antibody initiates the, because antigen antibody complex here, complement mediated lysis, which is the thing that is going to be destroyed. The virus which has infected the Th cell and that GP120 which is bound to the CD4 receptor, okay, and that has made the antibody come and bind to that CD where the GP120 is bound on the Th cell and cause Th cell instead of the virus. So because of the Th cell, those Th cells will be destroyed. Second, that antibody that is bound, GP120 antibody bound to CD4, can also trigger ADCC response, and that ADCC response will target the Th cell. And by targeting Th cell, the Th cell will be destroyed by the other cells like NK cells, eosinophils, neutrophils, and macrophages. And that is how GP120 mediated, complement mediated lysis and ADCC response can take place on the Th cell, leading to depletion of the CD4 positives. And CD4 positive T cells are nothing but Th cells. Peripheral blood of the person, CD4 positive T cells will be depleted. Because of that, those B cells, it will be dependent on those Th cells for their acquired immune response, will be now not getting the signals from the Th cells for the cytokines that are required by the B cells for their growth and proliferation and class switching. Because of that, that B cell response, which is supposed to be produced, also will be, there will be total immune suppression. And thank you very much.